So welcome. In today's session, we'll be discussing cerebrospinal fluid. We discuss the composition of cerebrospinal fluid, its production, circulation and absorption, and some clinical correlations. Welcome all, my name is Rosmain, and I'm your doctor. Now, composition of cerebrospinal fluid. Now, cerebrospinal fluid is a clear, colorless, and slightly alkaline fluid which has a specific gravity of that. Now, it contains inorganic salts, okay, traces of proteins and glucose similar to that of blood plasma, but its protein content is lower than that of plasma. Also, the glucose content is about half of that of plasma, but the chloride content is slightly more, okay? And here you can see in the CSF, you have 25 milligrams per 100 ml of proteins, but in the blood is 600. You can see that is about how many times? 24 times. Yeah. Then glucose, you can see here is 50, means 100, that is twice. Here you can see is 120 in the CSF and as compared to 100 in the plasma. So you can see the CSF chloride position is higher. Now, what is the appearance of CSF? Now, in an adult, we have about 150 ml, okay? And this is how it is distributed. 20 ml in the ventricle, 60 ml in the subarachnoid space, and 70 ml in the spinal canal, okay? Now, normal CSF looks like this. It is crystal clear, and its consistency is like that of water, okay? But when you have meningitis, okay, the CSF tends to be turbid, okay? It can be described as turbid or cloudy. And upon a microscopic examination, you will find increased numbers of polymorphonucleic cells or leukocytes. The neutrophils will be, the neutrophil count will be elevated. Also, in some cases, it can be described as xanthochromic, as shown here, or in some cases, especially after trauma, it can be bloody, okay? So, where is CSF produced? Now, about 80 to 90% of the CSF is usually produced in the choroid plexuses in the lateral ventricles. The remaining is being produced in the choroid plexuses of that and the fourth ventricles. Now, the process of production is debated to be either secretion, filtration, or dialyzation. Okay, so between the three processes, the exact mechanism is still uncertain. Now, about half a liter of CSF is produced daily. Now, let's look at circulation and absorption. Now, I've told you that 8 to 20% is produced in the choroid plexuses in the lateral ventricles. Now, once produced in the lateral ventricles, it usually passes to the third ventricle via the interventricular foramina of Monroe. Then, via the cerebral aqueduct of Sylvius from the third to the fourth ventricle. Now, then from the fourth ventricle, it will escape into the cerebromedullary cistern or the cisterna magna via the foramen of Magen or the median aperture, and also from the fourth ventricle it can enter the pontine cistern that is via the lateral apertures of Ruschka or the foramina of Ruschka. Okay, so the fourth ventricle, it has a median aperture, one median aperture, which will drain the CSF into the cisterna magna or the cerebromedullary cistern, and the two lateral apertures or the foramina of Ruschka, which will drain the CSF into the pontine cistern. Okay, then from these sides, it will flow to the subarachnoid spaces over the brain and spinal cord. Okay, then most of the CSF, after entering the cerebromedullary and the pontine cisterns, will flow upwards through the gap in the tentorium, the tentorial notch, and then forwards and laterally over the inferior surface of the cerebrum, where then finally it will ascend on the superolateral aspects of each cerebral hemispheres to reach the arachnoid villi and the granulations where it will penetrate into the superior sagittal sinus. So please note that most of the CSF is drained via the superior sagittal sinus, okay? And remember, the superior sagittal sinus will eventually form the right transverse sinus, then the right sigmoid sinus, and the right internal jugular vein. That is why the right internal jugular vein is larger than the left, because the left is a continuation of the inferior sagittal sinus. After then it merges with the great cerebral vein of Galen to form the left. It will go eventually to form the left transverse sinus and the left sigmoid sinus, then the left internal jugular vein. Now, CSF enters the bloodstream through the mesothelial cells which line this villi and granulation. Now, however, some of the CSF, not all of the CSF will pass superiorly. Some will move inferiorly into the arachnoid space around the spinal cord and the cauda equina. Okay, and not all will be absorbed via the arachnoid villi and the granulation. Some will be absorbed into the pyoveins. Now, the flow of the CSF is maintained by pulsation of the cerebral and spinal arteries, which are present in the subarachnoid spaces, and movements of the head and spine. So these two mechanisms are important for the movement of CSF or the flow. Now, this is how I was saying, produced in the lateral ventricles, then by the intraventricular foramen of Monroe, enter the third ventricle, then the cerebral aqueduct of Cerevius, move to the fourth ventricle, and from that it can either enter the central canal of the spinal cord or the subarachnoid space around the spinal cord and cauda equina. From there it will be absorbed by the pyoveins of the spinal cord, but most of it will exit the fourth ventricle via the foramina in the roof of the fourth ventricle, that is the median aperture, the foramen of Magendie. This is one. Then the two lateral apertures, the foramen of Ruschka. From the foramen of not a foramina, from the foramen of Magendie, it will enter the cisterna magna, also known as the cerebromedullary cistern. From the foramen of Ruschka, it will enter the portine cistern. Then from there, it will flow superiorly through the territorial notch to reach the undersurface, the inferior surface of the cerebrum, then flow over the superolateral surfaces of the cerebrum to the arachnoid villi and granulations, where it will finally be drained into the superior sagittal sinus. Now, here you can see that lateral ventricle, interventricular foramen of Monroe, third ventricle, cerebral aqueduct of Cerevius, fourth ventricle. Then some will enter this central canal of the spinal cord, but most of it will enter the cerebromedullary cistern via the foramen of Magendie, then via the two lateral apertures to the pontine cistern or the cisterna pontis, then flow superiorly over the territorial notch, the inferior surface of the cerebrum, then over the superolateral surfaces to be drained into the superior sagittal sinus via the arachnoid granulations or the villi. Okay. Okay, I think that is that. So here we are, you can see these are the lateral ventricles. Okay, this is the lateral ventricle. You can see this is the anterior wall, this is the body, and this is the posterior horn, this is the inferior horn. Then here is this is the third ventricle. This is the third ventricle with its pineal recess here. And this is the interventricular foramen of Monroe. This is the site of intrathalamic adhesion. Then this is the cerebral aqueduct of Cerevius. This is the fourth ventricle, and this is the one of the foramen of Ruschka, and the foramen of Magendie will be somewhere here. Okay, so this is the ventricular system. Now, let's look at some functions. This is self-explanatory. So it cushions, it acts as a cushion. It is a shock absorber. It supports the brain and the spinal cord. Okay, and also it changes. It compensates changes in the intracranial volumes. Okay, it also nourishes the CNS. Okay, it also removes the metabolic waste products. Also serves as a pathway for pineal secretions to reach the pituitary gland. The pineal gland usually releases melatonin, which controls the circadian rhythm. Now, clinical correlations. Let's look at a lumbar puncture. And after that, discuss what is FROIN'S syndrome, then hydrocephalus. I'll take most of the time discussing this because this is important, but that does not mean the others are not. They are. So lumbar puncture. Now, this puncture should be done well below the termination of the spinal cord. Should be done below the corners medullaris. Okay, so you don't want to injure the spinal cord. Okay, and in adults, the corners medullaris is found somewhere between the intervertebral disc between L1 and L2. So you want to do somewhere a little bit lower. Okay, so how will you do this? You identify the highest points of the iliac crest, then you join you draw a horizontal line joining the highest points. Okay, and that line would pass through the fourth lumbar vertebra. So the interspinous spaces immediately above and below this landmark can be used safely, but the most preferred is between L3 and L4. Okay, so note that. Why? Because in this region it is more roomy and it contains only the filum terminale. It has the filum terminale internum. Okay, and the roots of the lumbar sacral and coccygeal nerves, okay, which form the cauda equina. Now, during this procedure, please note this: the spine must be fully flexed, and this can be done either by the patient is lying on the side or seated. Okay, so by doing so, the interspinous spaces will be open to the maximum extent, and the lower end, the corners medullaris, will be slightly raised. Okay, then the needle is usually passed inwards and somewhat superiorly or cranially, exact in the midline. Okay, the structures which will be traversed through are the supraspinous, interspinous ligaments. Then when the needle passes through the dura mater, a distinct feel of giveaway is felt. Okay. Now, occasionally, the root pain is experienced if the roots of the cauda equina are impinged upon, but usually at this level, L3 and L4, at the interspinous space, those roots forming the cauda equina will float free of the needle, so there'll be no injury to them. Okay, so you want to do that. You should understand that the needle should always go through the most preferred side is between L3 and L4. So I told you the spine must be fully flexed, so the patient can lie on the side as shown or when seated. Okay, you want the needle to go through there, and you drain some obtain some CSF maybe to run a diagnostic procedure. Now, what is FROIN'S syndrome, which is also known as loculation syndrome? Now, imagine you have a block in the vertebral canal, okay, and this will prevent fluid passing the obstruction. Okay, so the CSF below the obstruction will show some special features. One, in that it coagulates spontaneously as the amount of protein is greatly increased. Okay. Two, it may be yellow in color, like plasma, so xanthochromia, due to altered blood pigment. Also, there is sudden increase in intracranial venous pressure because it is not transmitted to the CSF below the point of block. So, FROIN'S syndrome or the loculation syndrome is due to a block in the vertebral canal. Please note it is in the vertebral canal. Okay. So, let me show you how the kind of CSF you find when you do a lumbar puncture of a patient having FROIN'S syndrome or the loculation syndrome. It would be such color yellow, like it looks like plasma. So xanthochromic. This is normal, the clear one, crystal clear. Okay, now let's look at hydrocephalus. Now, hydrocephalus is defined as an abnormal increase in the volume of the CSF within the skull. And it is characterized by excessive accumulation of CSF either in the ventricles or in the subarachnoid spaces. It can be caused by either one, excessive production of CSF, which is not common, obstruction of some part in the circulatory route of the CSF, which is the most common cause, or interference with the absorption of the CSF. Yes, so please note that this is the most common. Yes, the production is normal, but there is an obstruction. So there is the flow of CSF is obstructed. It accumulates within the the ventricles or the subarachnoid space. And yeah, so let's look at where can this obstruction occur. It can be within the ventricular system, and the most common site include interventricular at the intraventricular foramina of Monroe, at the cerebral aqueduct of Sylvius, or at the foramen of Magendie or Luschka, the roof of the fourth ventricle. It can, when you have an obstruction in the interventricular foramina, what will develop is there'll be distension of one or both of the atrial ventricle, depending upon whether one or both of the foramina are blocked. So when one is blocked, there'll be a unilateral distension, but when there is a bilateral blockage, there will be a bilateral distension. Now, obstruction of the cerebral aqueduct of Sylvius will lead to the distension of both the lateral ventricles and the ventricle. You understand why? Now, what about if you have obstruction at the openings of the roof of the fourth ventricle, that is the foramen of Magendie and the foramina of Luschka? There'll be distension of all the ventricles, the two lateral ventricles, the third and the fourth ventricle. Also, there can be an obstruction at the opening of the tentorium cerebelli. So there'll be the structures below will be affected or be distended, because now the CSF cannot pass superiorly to access the inferior surface of the vein, but then the superolateral surface of the cerebrum to be drained into the superior sagittal sinus by the arachnoid granulations. Now, there are two types of hydrocephalus. It can be either internal or non-communicating, or external or communicating. Now, when it is internal, CSF usually accumulates within the ventricular system, and it occurs due to a blockage at some point between its site of formation, the lateral ventricle, and at the site of exit through that is via the foramen of Magendie or the foramina of Luschka. When there is a blockage between those 2 points, that would be there will be accumulation of CSF within the ventricles. So that will be an internal or a non-communicating hydrocephalus. What about an external? Now, CSF accumulates, in this case, CSF accumulates in the subarachnoid space. Okay? In this case, there is no obstruction within or to the outflow of the ventricular system. In this case, the ventricular system is fine. Now, what causes this is due to blockage of the arachnoid villi or granulation tissue. So CSF cannot now drain back to the superior sagittal sinus, and this can occur after meningitis. Okay, now hydrocephalus is most commonly caused by stenosis of the cerebral aqueduct of Sylvius. Please note that. Now, how does it present clinically? Let's discuss these 10. Now, there is a disproportionately large size of the head, increased skull circumference. Then the forehead will, there'll be bossing of the forehead. Then the sutures will be widely separated. The anterior fontanelle is enlarged and tense. Then the scalp is thin with dilated scalp veins, which are even visible. Then the eyes, they usually look downwards, which give the typical setting sun appearance. Then on skull percussion, there'll be a cracked point, a cracked pot sound. Then cranial nerve paralysis are common. Then there is also progressive loss of motor function, and dementia is present. So let's look at this. You can see the anterior fontanelle is enlarged and tense. The sutures here are widely separated. You can see disproportionately large size of the head. You can see this head is very large. Then you can see thin scalp with dilated veins. Even you can see here vein. Yeah, you can see the scalp is extremely thin. Then you can see bossing of the forehead. Okay, and reed retraction. You can see upper reed retraction. Then these eyes, you can see they are looking downward. The typical setting sun appearance of the eyes. Okay, so this is hydrocephalus. So please note this. And when there is this hydrocephalus, please don't be tempted to drain CSF from the anterior fontanelle, because that can be detrimental, because you know the cerebrum is now just below that, and you can injure the the cerebrum, where you are attempting to save the patient. Actually, when you try to drain CSF here, you are more likely to kill that child than save him or her. So it is better to conduct imaging. You see where the obstruction is, then surgery might be conducted. So I think I've come to the end of that session, and thank you for your attention, guys, and follow for more med content. Thank you.